So yeah, hi, I'm Tim. I've come down from Edinburgh. I'm a neurologist and a researcher. So I spend part of my week looking after people with neurological conditions, and I do a clinic for people with cognitive problems, including dementia. And then I spend the rest of my week doing research to try and better understand dementia on cohorts like UK Biobank, including UK Biobank. So I'm going to talk about dementia and UK Biobank and why I think researchers will be increasingly turning to UK Biobank to try and answer their important questions in the field of dementia. But I'm going to start by just covering briefly what dementia is. It sounds obvious, I think you probably know, but it's important, I think, that we set a definition so we all know what we're talking about. And then I'm going to say why I think it's important that we study it, why we should care. And then I'm going to say why I think researchers want to use Biobank to study dementia. And then lastly, I'm going to talk about some work we've been doing in Edinburgh, looking at how we can identify who develops dementia in Biobank to try and facilitate research. So what is dementia and why study it? Well, it's really simple, really. Dementia is a brain problem. It affects some form of cognitive function, so some form of thinking, memory, language, personality. It gets worse over time, and it causes functional impairment. And by what I mean by that is there's something that the patient can't do anymore that they would want to do because of their memory problem or because of their language problem. So that's all it is. So it's a complicated word for something quite simple, and there are many types, many causes of dementia. We call those subtypes, of which Alzheimer's disease is the most common. There's other ones there on the screen that you may have heard of. And there's a long list. These are the more common ones. So that's what dementia is. Why should we care? Why study it? Well, let's look at the numbers. So this is probably high now. About 700,000 people living with dementia in the UK. It's a common problem. And for all those 700,000 patients, of course, there are families affected by the condition as well, and people affected that might be informal carers who aren't paid for the work that they do, that have to look after their loved ones. And what that means is that it's estimated about £12 billion are spent every year in the UK on the health and social care costs associated with dementia. So it's common and it's an expensive condition to look at. And things are going to get worse because, the good news is that we're living longer as a population. But what the downside to that is that because we're living longer and age is the major risk factor for dementia, more people are going to get dementia. So it's estimated that if you're born in 2015, 1 in 3 people will develop dementia at some point in their life, unless we can find some way of preventing these conditions. So that's the numbers. And those numbers, those sort of terrifying numbers that you'll see plastered across the front page of newspapers are why the government and research funders are throwing money at dementia research to try and help answer these questions. And that's why it's important to funders. But of course, the reason it's important to patients and to the families and their doctors is the effect it has on the individual, on the lives of people. And sadly, dementia is common enough that probably many of us in this room have been affected by these conditions and know firsthand what it feels like. So that's why we should care. That's the real reason we should care. So there's money now to study dementia. That's changing. And researchers are going to want to use UK Biobank, and they are using UK Biobank to answer these questions. But why? Well, Tom's touched on some of these things. There's huge interest in genetics in dementia. Now, we know about a few rare genes where if one gene is affected, you will get dementia, and those people get dementia at a young age. Those of you that have seen the film Still Alice, that's what she has in that film. So that's a rare type of Alzheimer's disease where a single gene. That's important because it tells us it's important for those people and their families, and it's important so we learn more about diseases. But perhaps more importantly are the genes involved in typical, your average dementia that affects people in older age. There's a lot of interest in understanding those genetic risks more. And because everybody in UK Biobank's been genotyped, researchers can use that enormous resource to understand genetics. I won't touch too much on imaging because you're going to hear more about this later. But part of the imaging study is people having MRI brain scans. That's 100,000 people getting MRI brain scans. Just to put that in context, when you look in the dementia literature at studies done on dementia, we've done MRI scans on 50 people or a couple of hundred people. 100,000 is several orders of magnitude bigger than what is currently out there. This is a phenomenal resource for people. Tom mentioned accelerometry, the wristwatches that measure activity. There's a lot of interest in activity and its association with dementia. It also measures sleep. That's an increasingly controversial area, effects of sleep on dementia. You all did cognitive tests at baseline, and then a significant proportion did cognitive tests a few years later. That's already the world's biggest ever study of repeat cognitive testing. So if you want to understand what normal aging cognitively is like versus abnormal aging, this is a resource to turn to. We've got lifestyle information, so we can understand about risk factors from our lives that might influence our dementia risk. And then, as Tom mentioned, there's been other questionnaires, a lot of interest in mental health and its relationship with dementia, occupation and diet. And we've got a lot of these bits of information in 500,000 people. And as Tom mentioned, when it comes to doing these sorts of analyses, we need numbers, and that's what UK Biobank provides. So I've spoken about why I think dementia is important and why researchers want to use Biobank to study dementia. So I'm lastly going to touch on some work we've been doing at trying to help researchers use UK Biobank to identify who develops dementia. So UK Biobank's a cohort study. So by that I mean a group of people, you, signed up at baseline, that's it depicted in this image, and then time passes. And those things that we measured at baseline are there fixed at baseline, and then over time, people develop certain health conditions. We can then look back, when we know who develops those diseases, in this case dementia, we can look back and say, well, those things at baseline, was that a risk factor for dementia? Did that affect that person's dementia risk in some way? But of course, to do that, you need to know who develops dementia. Otherwise, you can't do your analysis. In this case, the pink people in this picture are the ones who've developed dementia. We need to identify those people. And there's a few ways you can do that. So you could write to people, or you could send them an email and say, have you developed dementia? Well, that's a method, and it's what some cohort studies do, but you can immediately probably think of some issues with that. So we know, for a start, that 2/3 of UK Biobank participants have email, but a third don't, so you instantly can't reach a third, and you might worry, appropriately, that third who don't have email are not the same type of person as the 2/3 that do, so that's going to be an issue. The other thing we know, and we've done some, I mean, it sounds obvious, but we did the research to prove it, is that the people who don't respond to requests to come and attend things and with regards to a cohort study, they're the people at the highest risk of getting dementia. So just by you all being here today, you've done a fantastic job at reducing your dementia risk. Congratulations. So the problem with that is something called selection bias. So what we mean by that is that the very people you want to try and identify aren't responding to your requests, and that means your sample's biased. Your sample's not typical of the general population you're trying to study. That's an issue with other types of cohort study. So UK Biobank's taken a different approach, and Tom touched on this. They've used something called linkage to data sets that are generated from everyday healthcare encounters. So we're very fortunate in this country to have the NHS for many reasons. One of them is for research. So we only have one provider to go to try and access these informations. You couldn't do this study in America because of the amount of different hospitals and companies involved. So you have a person. Every time somebody's admitted to hospital or sees their GP or a blood test is done with either their GP or they die, that information is collected and coded and stored. So you can collect that information, link it to individual, and then you've got this picture of their life that's passive. So that person doesn't need to respond to questionnaires, doesn't need to have an email address, it doesn't matter. We can find out what conditions they develop through linkage to these systems. And they're called routinely collected healthcare data sets because they're not collected for research. They're collected for everyday routine NHS administration, and they have been for a long time, but they can then be made available for research, so they've got a secondary purpose. But there's no point using these if they're not accurate. If you have a flag, a code in someone's GP data that says they have dementia, if they don't actually have dementia, it's a useless way of identifying people with certain conditions. So we had to look at that. So this is what we did in Edinburgh. We came up with a code list, a huge code list, about 150 codes, that we thought would identify people with dementia in hospital, death or primary care data. And then we looked at people recruited in the Edinburgh area, and we looked to see if they had any one of those dementia codes in any of their data sets. If they did, we went to their health record, so their hospital electronic health record, where there's letters, inpatient letters, outpatient letters, some GP referrals, and test results. And we extracted the information, anonymized it, and then gave it to a small group of dementia experts, and just asked the question, okay, this person has a dementia code in our data set, do they have dementia? And if they do, what subtype of dementia do they have? And that lets us calculate the accuracy. It's quite a simple study. And this is what we found. So if you have a dementia code in hospital data, 87% of the time that's true. That person did have dementia when you look at their records. It's 80% for death data. And there's reasons why that might be lower. And 87% for primary care data. And that was a bit of a surprise because those numbers aren't 100%, and you might be surprised they're not, but we wouldn't expect them to be really. And for most types of research, that sort of number, mid-80s, is good enough to identify people for your study. And primary care data is interesting because 87% of the time people did have a diagnosis. Now you might say, well, hang on, are these GPs making diagnoses? Surely they're not as good as the hospital doctors making their dementia diagnoses. Well, the GPs might disagree and say, I'm just as good at making a diagnosis as you, thank you very much. But what we actually thought when we turned to their records is what GPs are doing appropriately is they're referring patients they're worried about to hospital who are seen in outpatient data, so seen in hospital outpatients. And the outpatient doctor is writing a long letter, sending it to the GP, and the GP is coding that appropriately. Now, you don't get that in hospital admissions data because that only looks at people admitted to hospital overnight, whereas this is GP data is a way that we could capture what's happening in hospital outpatients because GPs are so good at coding the diagnoses from letters they receive from specialists in secondary care. So primary care data was accurate. We were pleased by that. But something else important is that primary care data found people that we wouldn't have found if we only had hospital or death data. So this Venn diagram is proportional. So what that means is the bigger the circle, the more people in it. And what you can see on the left there is that about half of people are found only in primary care data. So most cohorts traditionally in the UK only use hospital and death data. Now, if we did that, you would never know those people had dementia, and you would wrongly, in your analysis, call those people non-dementia cases. They would be on the wrong side of your analysis. But with primary care data, you can see that there's people there, half of people that you find only in primary care data. And UK Biobank's really led the way in trying to get linkage to primary care data for its participants because it was understood that actually many of these conditions, like dementia, that aren't dealt with so much in hospital, that are dealt with in the community, that's where we're going to find these people. That's where we're going to find out if they have dementia. So we've done that, and we think these data sets are accurate. Then we need to see if we can help other researchers use UK Biobank data. So this is a mock-up, it's not real, but of what these data sets look like. It's pretty dry and boring, okay? Let's face it. So this is an ID. This is all one person, so they have the same ID. We don't know their name, they're anonymous. They have a series of dates, a series of codes that reflect some sort of diagnosis, and the source. Did it come from GP data or hospital data? And there's rows and rows and rows. You think every time you've seen your GP or your GP's done a blood test, a new row of data is generated. So for one person, you might get hundreds of rows. So imagine that for 500,000. We're talking millions and millions of rows. As I came into this as a naive doctor, the first time I got access to UK Biobank data, I sent an email to one of my colleagues who's used to dealing with these big data sets. And I said, I've just received the UK Biobank data, I'm going to open it. I just sent the email. And then it turns out he'd immediately replied saying, do not open that data set in Excel, which is exactly what I tried to do. And my computer crashed and was never the same again. So, if I'm a geneticist interested in using UK Biobank, or I'm an imaging specialist, I don't want to be dealing with these millions and millions of rows of data if someone else can do it for me. So we applied what we'd learned to try and use an algorithm to say, okay, in the background there's all these data sets, just spit out the answer, does this person have dementia? Yes, no, and if yes, what date were they diagnosed? That then means that researchers don't have to keep going back to these millions of rows of raw data. They can just use that. It speeds up research and helps pass our expertise on so that people who are experts in other areas can use what we've learned for their analyses. So we've done that for dementia. But of course, what I've said here applies to any condition. It doesn't apply just to dementia. So our group in Edinburgh, led by Cathy Sudlow, who's Chief Scientist of UK Biobank, have worked on many different conditions that you'll see here, and there's more. So everything I've said here will apply to these other conditions as well, trying to generate algorithms that spit out, does this person have this condition, yes or no? So to summarise, I think I've tried to pass on that dementia is important and that we should care about it. We've shown that we can use these routine NHS data sets to identify who develops dementia. I think I've put across that primary care data is a useful resource, and Biobank's led the way in the UK in accessing primary care data. And I think I've shown that UK Biobank is a powerful resource for dementia research. And I think as time goes on, researchers around the world are increasingly turning to UK Biobank to try and better understand these conditions so they can try and ultimately help patients and try and reduce people's chance of getting dementia. Thank you very much.